Good morning, everybody. How's the audio? Looks like
Yep,
I'm
you're
not
good.
muted.
You're,
Perfect.
yep.
How's everybody doing? Thank you guys for joining today. My name is Omid. I'm from Modern Practice Solution. We're a medical billing company, providing a few administrative services as well, but our main focus is billing and AR collection. And today's presentation will be, as Cindy has already named it, Party Like It's 1999, but don't bill that way. I think she said please, but I'm not as prim and proper as she is or cordial, because I get to deal and have to help coach providers in the repercussions of billing like it's 1999. So what I'd like everybody to do is in the chat, if you can think of maybe one or two things that you don't have to do I'm sorry, it's not something that you may be doing, or maybe something you've done in another practice, but some archaic, maybe that's not a nice term, but a practice in your a practice protocol, or just standard way that you do things that is just not,
not kosher.
With the times. So something in billing, for billing related. We can talk about other things, and I may have touched on it. So today we want to talk about some of those items to kind of keep with it. Something that I hear often when we speak with new providers or new clients, or at least during the initial call where we see if it's a good fit, is, but we've always done it this way. If you can see my skin crawl and how anxious I get and tense I become when I hear that, it's not always a good thing that you've always done that way. It's not always a bad thing either, but I think something we need to know, keep in mind as we grow our practices, as we move forward into the new era, is that the ways we've done it in the past are not always the best. So we may have always printed, and I haven't not been in this industry since 1999, but some of you may have, some of you may not have, but just keep in mind there are things we've done in the past that was always allowed, and it may have been the new and best practice for billing, but in 2023 and about to be 2024, that's not exactly the case. With the new age, we need to lean on automation, standard protocols, keeping up, and not just billing and hoping things pay, but instead we have to be a little bit more aggressive because everybody's cheap. These insurance companies don't want to pay. They're going to come up with any excuse not to pay, and we've just seen a laundry list of issues that we haven't seen in the past. But at the same time, it's about pivoting. And then, when I say pivot, I always think of the Friends where Ross is yelling pivot, pivot. So we have to pivot, and we have to constantly keep pivoting to keep up with this industry. Just, if you don't, that's okay. The only person suffering is you and your bank account. So ultimately, we have to keep up unless you're okay with having a little less in that bank. So one of the big first ones that comes to mind is E&Ms can be billed each time because it's an office visit. I've been scolded a couple times for using the term office visit by Cindy. It's an evaluation and management. So I've, for the most part, fixed it in my brain. But remember, when we do a true evaluation, that is the only time we can bill an E&M. There are other codes we can bill for outside treatment or care where the patient's not in front of us, but billing an E&M every single time the patient comes in is not always appropriate. And we'll piggyback on this concept throughout this presentation, because what I want us to keep in mind here is every time they come in, it's not an office visit. Today may be an evaluation. Next time they come in may be an injection that we knew about. We wouldn't bill an E&M there. Or maybe they're coming in for at-risk foot care. We don't bill E&Ms for at-risk foot care. They're two different items, and we're representing two different things if we bill it to the insurance company.
And these are things
so ensuring we're reporting.
These are things that I just don't like to hear, because they're thinking and saying, well, we get paid so little for just the procedures, the debridements, whatever. We have to throw in the E&M in order to make some money. And number one, the insurance companies don't want to pay you on established visits for an E&M unless there is a legitimate reason for it. And they will ask you to show them why it's legitimate or not. So this isn't necessarily good news in terms of the bottom line of your practice, but we're trying to help you to avoid more audits than you're getting now, to pass when they ask to review charts, and basically, to keep you out of prison, because I'm not going with you, and I know Omid doesn't want to go. So that's what we're trying to do here, is not necessarily bring you great news about how to appropriately bill, especially with E&Ms, just throwing them on. But you have to do it the legitimate way.
So yes, exactly. So at the same time, this is a little bit redundant, but E&M should always be billed because we evaluated the patient. That's not always the case. So this goes back to us knowing the patient's going to come in next week for an injection. Each procedure has an E&M component. We don't just, see the patient and then we just inject the patient that next week. So that evaluation has a component, that procedure has a component of the eval to make sure that we still want to do the procedure. If you're doing a full workup, of course, we should consider billing an E&M. But if it's just an injection visit or just an at-risk foot care visit, or we know we're always going to do nails and calluses every 60 days or 62 days, whatever your protocol is, that does not necessitate an E&M. So please just keep that in mind when you are doing your coding. Billing E&Ms when we don't meet nail and callus care procedures with cost findings, referring providers, date last seen. Yeah, the at-risk foot care is a pain to keep up with. It's annoying to have everybody on deck just waiting to collect that information, put it in your EHR and put it on the bill. But billing an E&M because nails and calluses are not covered is not appropriate. The insurance companies have caught on. If you're billing B351, and I always butcher that word no matter how many times I've tried, and there's a reason I'm not a doctor because I can't pronounce anything, but B351 and an E&M, they're going to know that that's for nails. Or if you have L84, they know that that's for calluses. So we shouldn't be billing a 99213, even if it pays the same. To them, if you report the wrong item, they will take the money back. They will somehow find it. They don't always find it. And I'm not going to lie to you and say everybody's going to be audited and write millions of dollars back. But at the same time, preventing any reason for these insurance companies to take the money is important. So what I ask of you is bill what you do. E&Ms are not the same as nail care and calluses. And just because you didn't meet those requirements doesn't mean we bill an E&M. It means we may need to charge the patient cash. And this goes back to one of the topics Cindy talked about earlier, is engaging everybody in the whole patient experience. Anybody in this office that it has any sort of exchange with the patient is part of that experience, and that is what's most important with your care. Send notes and they will pay. So I hear this all the time. It's denied, and we reach out and say, hey, it doesn't look like you're at medical necessity. Your diagnoses don't support it per their medical policy, and they have providers that say, just send my notes. It'll get it paid. I hate to break it to all my providers, but your notes are not always the greatest. And I'm not trying to hurt anybody's feelings. I'm not trying to break anybody's heart or burst your bubble, but it's true. Your notes don't always support it. In your head, you know what you did and you know the justification, but it's not always detailed in your notes. So leaning on your EHR to have certain templates to add the fluff. And I hate using the word fluff for this, but it's important. You have to have that narrative, the details, and the nitty gritty to back up what you're saying. Because we have like scribbled. We used to scribble on a piece of paper, did this, did that, and you know the backstory. But here we have to be as detailed. You're writing a book report, essentially, is what we're doing to these insurance companies.
And in the very next presentation about surviving audits, winning audits, we'll talk more about the importance of documentation.
Podiatrists are only allowed to bill level 3s. That's no longer a thing. You should and can be billing level 4s and 5s. I often speak with providers that have been in this industry for years and decades, and they still have a very high level 3 distribution. And sometimes that's perfectly appropriate. But if we're dealing with patients that need medications prescribed, or you're opting for surgery, those should not be level 3 E&Ms. Again, it goes back to your documentation, but level 3s are typically for, low medical complexity. The course of care is minor and minimal. And we'll look at some of the E&M, how we code it in the past and how we code it now, just to kind of briefly touch on it. And if you don't have that sheet, which we'll look at in a second, I encourage you to print it out and put it in your office, put it underneath your keyboard or somewhere so you can refer to it when you are doing your coding.
And in my library, I have presentations on, the E&M changes as of 3 years ago, and some examples per APMA. So we know that, if APMA said it, then most would agree. So just examples of what you're seeing as a new and established patient. And I feel that since the E&M kind of rules changed, that as podiatrists, you have more of an opportunity to bill for higher level established E&Ms than you do for initial, because if something's exacerbated long-standing, you have to change up the whole care plan. Now it's higher risk. Now you're talking about surgery. That is legitimately, a 214.
The next one is using same coding modifier combination because it pays. On my side as the biller, my team often sees some providers that opt for the exact same coding combo. So if the patient's coming in for at-risk foot care and they have nails and calluses, let's say in Florida, every nail care has B35-1, and that's all you need to meet medical necessity in First Coast service options. Or on my West Coast providers, a lot of them, especially Cali, it's like they have B35-1 in pain, and then L84 in pain, and that covers you on the West Coast. So just having that as the exact same thing for every single patient is not the best. They're catching on to these items. So one thing that I constantly am getting emails about or forwards are the comparative billing reports from Medicare. That's them looking at the data. Yes, they pay it and we got the money, but that doesn't mean we're going to always be able to keep it. And they're looking and analyzing the data that we submit to them, so they know we are sending the exact same coding combination. Yes, some of them may be the same, and I totally agree that they should be the same. But if a patient has diabetes, but we're not treating them because of the diabetes, we're doing it because of B30, sorry, I butchered that, I know I did, in pain, then, that's not, from your standpoint, if you document it that way, I'm sure you're fine, but the insurances know that the patient has diabetes. So just keep that in mind. These insurance companies have more data than we do. They have information from the patient's endocrinologist or primary care provider, the nephrology clinic, vascular. They have everybody's codes and diagnoses because they're paying it. We only see our subset. So if you think, oh, I'm going to leave diabetes off, you're not slick. These insurance companies know. So keep that in mind as you choose the diagnosis codes for your patients. Not knowing your medical policies. So, these are some of the things I've heard as well. I'm billing it because the doctor said to. Yeah. And this is definitely a moral issue I have with the insurances, because I'm super against the insurance companies. They're practicing medicine without directly practicing medicine. They're telling you how to practice. But until we figure out how this healthcare system needs to be revamped so everybody is taken care of, we kind of have to play their game. So when that game is listed, we have the rules with medical policy. So I encourage everybody, at least at some point in the year, read your medical policies at least once a year to refresh your mind what is covered. If you're doing certain things like a wound, you have to stage up. You don't get to just come in, the patient has a wound and slap the graft on it. They're not going to pay. They may pay it, but they're going to audit. And that's going to lead into next presentation with Dr. Sedberry about how to make sure you are winning and how to make sure you are checking those boxes. Some other things are assuming everybody will pay you. Docs that say, oh, I get paid on everything. You don't even have to look at my codes, just send it out. Yeah, that's never the case. And I think everybody on this call, our administrative staff, any billers, I see some office managers I've worked with, that's not the case. And you know that. And then the opposite is, we're assuming nobody will pay you, so you overbill. And this goes to billing an E&M for every visit, because we're going to throw it and hopefully something sticks. So if I bill $1,000 because I bill an E&M, nails, calluses, and I'm going to do the trimming, and I'm not even going to throw on my procedure, my A code for the supplies. Hopefully it pays. That doesn't always work, and it shouldn't work, because we should, again, code for what we do and collect for what we do. I'm going to take a little dig at our providers for a second, but our documentation, scribbled notes are not acceptable. I still have providers that I work with that handwrite their notes, and it doesn't work. These insurance companies will not accept those handwritten notes. Some have policies now that say they will not accept it. So if that requires you reaching out to a company that does virtual scribe services or something like that, we need to look into that, so it can be transcribed, translated, whatever. Have a scribe in the office or somebody listening in during your visits to document as you go. We need to find a solution for that, because the handwritten notes, they will not pass anymore. Documenting the review of systems and HPI are check boxes. So prior to 2021, we had this grid right here. This is from Novitas. So if you're in like the Texas area or the Northeast up until New York and a little bit south, you may have seen this grid. This is no longer our checklist. We don't have to have we have chronic conditions, that's a separate thing for the new E&M, but we don't have to have 4 boxes in our HPI and 9 checks for review of systems. What we need to do is code for medical necessity and code for med legal purposes. If it's impacting your care and you're assessing and evaluating it, we need to document it. But if it's not something in your purview, like, you should not be documenting breast exams unless you really need to for your care. And again, I'm not a clinician, but to my knowledge, we should not be doing that or doing any, urinary tract. We don't care about that stuff. Our focus is going to be below the knee. If there's cardiac issues or other items like that, then yes, of course, we need to document that, but only document what's necessary. This also can play a role with your EHR. Sometimes your EHRs just have the standard review of systems. So the patient's checking all these boxes and it gets imported into your note. By putting it into your note, they're saying you've reviewed it. This is part of your assessment. This is part of what you discuss with the patient. So we don't need to have things that you don't treat. We don't need to have things that you don't take care of, because at that point, again, talk to your attorney. I'm not an attorney, but that could make you liable for something that may have been missed. It may not be in your purview, but document just for what's necessary and what you need to do to come up with your final care plan. So the new E&Ms and old E&Ms, you did change. So this is what the AMA has published as like their change. They completely scratched out majority of this and then went straight to medical decision making in time, which to me was the best thing ever, because you get to be paid for now what you do rather than how many check boxes. Because I could check as many boxes and your templates did it already. But they realized, I hope they realized, again, I'm not them, that that was not the solution and not the answer. So this is your new E&M guidelines. Please, please, please take a look at this, spend time, memorize it, commit it to memory, realize when and where you fall on this grid. You need to have 2 for established and all 3 for new. So if you have a prescription and the patient has 2 or more chronic illnesses that you're treating, we have a level 4. It's pretty simple. So just take a little bit of time, assess it. This presentation today is not about E&Ms. Again, Cindy has those in her library. Take some time there. Document when they ask for notes. So when I ask my providers, hey, we couldn't find the notes in the system, can you upload them? I'm sure some of them are writing their notes right then and there. And it drives me crazy, but you should not be billing before you complete your notes, because it does change and they are time stamped. And when the insurance companies receive it, they're going to see it and they know when you're adjusting your notes or writing your notes later. So just be prepared for that. And then this last one is, I've never been audited before, so I'm doing things correctly. Audits are not always indicative of how well you've done. It's just you've been lucky. It's a new obstacle, and some providers have been fortunate and not ever been audited, and that just means you've kind of flown under the radar with your billing and coding. But that doesn't mean you'll always float. And at some point, everybody should be audited, and it's not a good thing. But at the same time, if you're doing things correctly, why are we worried? Why should you be stressed? Yes, yes, yes. There's money at risk. Your revenue is on the line. People are questioning you. I get that. But if you're confident in how you're practicing, and if you're confident with how you've documented and done everything in the past, not even everything, but majority of it, because nobody's ever 100% confident, right? We shouldn't be concerned. Just be prepared. That's the last slide I have here. Let's see some of the fun things we have.
Thank you, Omid. What I have Omid's contact information at the end of the entire meeting today. This is also recorded, will be in the library for my active